I'm Lauren Henke, and I'm joined by my co-host, Stephen Chun, for a new episode of the NRG Oncology podcast for March 2025 Kidney Cancer Awareness Month. Our guest today is Dr. William Hall, who has been highly active in the NRG-GU Core Committee and is the National Principal Investigator of NRG-012 or 12 for metastatic kidney cancer, also known as renal cell carcinoma. And for those of you who hadn't heard, Dr. Hall has recently been named Chair of Radiation Oncology at the Medical College of Wisconsin as well.
First off, Dr. Hall, I want to congratulate you on the chairmanship at the Medical College of Wisconsin. It's always a win for NRG Oncology when an NRG investigator is promoted. To get started, I wanted to talk about the concept of removing the kidney when we're talking about stage 4 kidney cancer, when it's already spread to other parts of the body. I think this is really important to discuss in historic contexts as background for your trial GU012. And the reason I say that is for most stage 4 metastatic cancers, again, when it's spread from the primary tumor site to other parts of the body, like lung cancer, like breast cancer, like pancreatic cancer, we really seldom pursue aggressive removal of the primary tumor, which I suppose is also called cytoreduction if we want to get technical about it. But what is it that makes metastatic kidney cancer different from other cancers, and where did this idea of removing the kidney come from?
Well, thank you both very much for having me, and thanks for your opening congratulatory comments. I really appreciate that. I think this is really wonderful that you all are doing this, and I'm happy to go through this. So, the history of NRG-GU012 is an interesting one, and that's a really great question and a great place to start out. And it goes quite a ways back where this question started in patients with metastatic renal cell. So going all the way back to 2001. Many people are familiar with sort of an iconic SWOG study by Robert Flanagan, published in the New England Journal of Medicine, that looked at using nephrectomies followed by interferon alpha 2, compared with interferon alpha 2 alone in patients with metastatic renal cell carcinoma. And it was shown really intriguingly in that randomized trial that there was an overall survival advantage associated with resection of the primary tumor in that patient population. And it was a modest advantage, but nevertheless, it was a compelling finding that led to a long-standing standard of care in patients with metastatic renal cell carcinoma that has been offered for many years, which we've frequently referred to as local cytoreduction. Now, fast forwarding, there have been multiple other studies that have changed the landscape of metastatic renal cell carcinoma over the past 6 years that have really influenced what we are testing and examining today. One of them was called the Carmina study. That was also published in the New England Journal of Medicine in 2018 by Arnaud Méjean from France, and looked at the use of nephrectomy in metastatic renal cell. But in this setting, patients were being treated with sunitinib, so different systemic therapy. Sunitinib is a tyrosine kinase inhibitor. So different systemic therapy, looking at the same question of, does it help patients to remove their primary tumor surgically? And in that study, there was no benefit. And if anything, when you look at the PSF curves, there appears to be slightly worse outcomes when a nephrectomy was added. So I find this really fascinating because it introduces a biological question. When you change systemic therapy and you perform the same type of randomization, the benefit is absent, which is very interesting. Now, around the same time, 2019, there was a study called CERTIME. This was published in JAMA Oncology, that looked at immediate, meaning patients were taken right away to the standard of care historically, which was cytoreductive nephrectomies, versus deferred cytoreductive nephrectomies, meaning they started on systemic therapy first, and then they received a cytoreductive nephrectomy at a later time. And that study interestingly showed that there was not a benefit to doing this sort of immediate or upfront cytoreductive nephrectomy. The winner in that setting was a deferred or delayed cytoreductive nephrectomy. So lots of interesting, really powerful scientific-based studies that have informed our standards historically for renal cell carcinoma. Now let's fast forward to GU12 and how we kind of designed this a few years ago. The standard of care systemically for patients with metastatic renal cell was really sunitinib for a very long time. And then there was a whole slew of trials that were mostly published in the New England Journal that set a new standard of care for these patients, which was a change to immunotherapy and various combinations of immunotherapy as standard of care. So naturally, we went back to the classic question that we've been asking in renal cell carcinoma, really inspired originally by the Flanagan-Swag study in 2001, which is when patients have immunotherapy on board, does it help to remove their primary tumor? So Swag redesigned an interesting study called the PROBE study. This is open and actively accruing. It's looking at immunotherapy alone versus nephrectomy plus immunotherapy, which is the experimental arm. So we at NRG said, you know, we have a fantastic modality with SABR to treat patients with renal cell carcinoma. It's quick, it's easy. Most clinical and preclinical data would suggest that it synergizes with immunotherapy. So it was a very natural hypothesis to introduce this into this patient population. And that really led us to the design and the current randomization of NRG-GU012.
So talking a little bit first before really diving into GU012 and its goals, with renal cell, like you've said, I really want to pull out a bit more. Like many other metastatic cancers, we've seen this revolution in the systemic therapy backbone, and we certainly see that in metastatic renal cell. It's hard to believe that just 20 years ago, the best options were things like interleukin-2 and interferon, which had a ton of toxicity and pretty limited benefit. Now, like you mentioned, we have tyrosine kinase inhibitors effectively tell the cancer cells to stop growing, and PD-1 or PD-L1 immune therapies, which help our own immune systems attack the cancer. Can you speak to that current systemic therapy landscape on its own and how that has factored into outcomes for metastatic renal cell carcinoma, beyond just, you know, the considerations of cytoreductive treatment? How do our outcomes for metastatic renal cell compare today with, you know, the early 2000s when we only had those limited drug options like interleukins to treat metastatic kidney cancer?
Sure. It's a great question. And this is really an incredible area of accomplishment for patients. And I always like to highlight how powerful randomized clinical trials are to advancing the outcomes of patients. And there's few malignancies that have benefited more than metastatic renal cell carcinoma. And if you look at the past 6 years, as I mentioned, there have been a number of prospective trials, a couple examples here, Checkmate 214 and the Keynote 426 trials that have looked at combinations of different types of immunotherapy. For example, nivolumab and ipilimumab compared with sunitinib in the Checkmate 214 study, or pembrolizumab and axitinib versus sunitinib in the Keynote 426 trial. And the outcomes are really impressive. I mean, when you look at the overall survival curves, there are very substantial proportions of patients living to, in many cases, long overall survivals, 20, 24 months. And if you look at the percentage of patients that are alive on some of these systemic therapies at 18 or 20 months, in some of these trials, it's upwards of 80 to 90%, which is pretty remarkable and is a very different result than the result that we saw back in 2001, where the median overall survivals were much less than that. So the question we're really focusing on now is we're getting really exciting systemic responses. We're seeing exciting and prolonged overall survivals compared with our other standards of care. How do we try and augment this and even further enhance these types of of responses that we're seeing for patients that are on immunotherapy.
So with all of this historical context out of the way, I was wondering if you might give us a brief overview on NRG-012 and really what are the major goals and where did this name samurai to describe the trial come from? For those of you who are listening, the name for GU12 is samurai, and I think many people when they hear samurai, they might think of the Japanese warriors or that Tom Cruise movie. But yeah, speak to us. What are the basic goals and where did this name come from?
Yeah. So the name came from an acronym. The full title of the trial is a randomized phase 2 trial of stereotactic ablative radiation therapy for metastatic unresected renal cell carcinoma receiving immunotherapy. So if you pull out some of the first letters of those words, the S and the A from stereotactic ablative, the M from metastatic, the U from unresected, the R from renal cell, we pulled a middle A from carcinoma, and then the I from immunotherapy, it's spelled out samurai. Now, the reason why trials typically have acronym type names is it really helps to promote and socialize the trial, and it makes it easier for investigators to reference the trial quickly when they're discussing trials at tumor boards. So I always like to mention to people if they're ever designing a trial that one of the first things to think about for a trial is coming up with a nice acronym for it because it definitely helps people to remember it and it helps people to quickly reference it when they're talking about potentially enrolling a patient on at their tumor board. It's just a little bit easier for us to remember. But essentially, the design of the trial is a randomized phase 2 trial that is a 2-to-1 randomization. We can talk a little bit about what that means, but it's a 2-to-1 randomization, meaning that it favors the experimental arm, which in this case is the addition of SABR or stereotactic ablative radiation, which is a high dose of radiation therapy to the primary tumor in combination with immunotherapy. Now, the immunotherapy is not given at the same time, but the immunotherapy is given before and after typically patients receive the SABR. So we hold the immunotherapy while the patients are receiving SABR, but then we give it sort of pre and post SABR. And it's really intended to be a trial that accomplishes a couple of different things. Number one, we wanted to test the addition of a robust and well-tolerated mechanism for local cytoreduction in this patient population that did not result in long delays in immunotherapy. So clearly the backbone of this malignancy is the use of immunotherapy. And so one of the challenges or the potential barriers that has been discussed for patients undergoing surgery is that there is a needed time for healing and recovery after an operation. And for some patients, that can be longer than others. So we really wanted to try to introduce a quick and efficient way to comprehensively cytoreduce the primary, which high-dose SABR is actually very effective at doing that, while at the same time not introducing long gaps in the administration of the patient's immunotherapy. So that
You
was
know,
the
you know,
primary rationale.
just for people who don't know much about SABR or stereotactic ablative radiotherapy, you say it's fast, it's high dose. Just how fast are we talking about, and how effective are we talking about for a
Yeah,
renal
great.
cell carcinoma?
Great question. So this is something that I think our specialty has to promote a little bit more than we currently do. But the outcomes for SABR in non-metastatic renal cell, so patients that don't have metastases, are truly remarkable. So one of the other co-leads on the study, Shankar Siva, has done just an incredible amount of work looking at the use of SABR in non-metastatic renal cell carcinoma. Now, this is very fast. In some circumstances, not in our trial, but in some circumstances, this can be just one treatment, an outpatient treatment where patients come in, they lie on a table for approximately an hour. They come off and they go home. No anesthesia, no cutting. They can drive themselves. It's really almost like a science fiction type treatment. Our treatment is 3 total treatments. So the patient has 3 visits for radiation, and there's almost always 1 extra visit for a mapping session or a CT planning session. But the reported outcomes of local control for renal cell carcinoma for patients undergoing SABR in some studies actually achieve 100%, which is really unbelievable. I mean, there are very few modalities that we can report in prospective trials that 100% of the patients enrolled had their tumor controlled. Now, there's a variety of those outcomes, but suffice it to say, the results using ablative high-dose focused radiation to the primary tumor are very good.
And just one other question on that note. What are some of the side effects? Because I know people are going to ask about, okay, sounds like a magic, beam that you're putting here. It's quick, it's outpatient, and it's almost, it's 100% effective. But what are the side effects here?
Great
And
question.
I guess how does the side effects compare to a nephrectomy or removal of the kidney?
Yeah, that's a great question. Well, I always like to tell patients every treatment that we offer has risks of side effects. It's a question of how common are those side effects and what are they? So the one thing I do want to highlight in this study is that immunotherapy by itself is in some patients can have a lot of side effects. So what we're sort of beginning to grapple with on this trial is what are the side effects that are attributable to radiation, and what are the side effects that are attributable to immunotherapy. If you look in the literature of non-metastatic renal cell, the most common side effects would be things like fatigue. Occasionally, patients will experience a slight discomfort or pain and it rarely needs medication to address. Some patients experience a mild sense of nausea. It's pretty uncommon though. I usually like to counsel patients that there is a small chance of injury to the normal kidney, meaning that their kidney could decline in its function or ability to perform its normal activities. And there's also, depending on the location and the size of the tumor, there is a potential risk of injury to the bowel, which in some cases can be either wrapping or touching these tumors. But for the most part, this is a pretty well tolerated treatment.
So I think that overview and description, obviously this is something that's potentially really appealing compared to a nephrectomy, which is obviously much more invasive. But, backing up from a standpoint of NRG oncology, to my understanding, Samurai or GU012 is the first time that NRG oncology has really gotten into the kidney cancer space in terms of trial evaluations. Why has it taken NRG oncology so long to pursue a renal cell carcinoma concept for a clinical trial? And what has that been like for you testing these waters as a principal investigator?
Great question. So it's taken quite some time, I think, for a number of reasons. First, SABR is relatively new. So the introduction of stereotactic ablative radiation, particularly for kidney cancer, is relatively new. It's been used in a lot of other settings. For example, early stage non-small cell lung cancer and oligometastases and prostate cancer and several other sites, but it really hasn't been used a lot in renal cell carcinoma, except for the past probably 7 or 8 years. There's been some major publications that have come out. So it takes time for these types of modalities to filter through into the cooperative groups before they're being formally tested. The other challenge is that oncologists are very protective and opinionated as to what are the best options for their patients, and rightfully so. And that really comes from decades of experience treating patients, many, many years of training programs where certain treatment strategies and various types of perceptions are ingrained into trainees' minds. And so there was a long period of time where the narrative was that renal cell carcinoma is quite resistant to radiotherapy. And that is absolutely not the case. Renal cell carcinoma, I really had not treated a lot of it in my training, but when you start treating renal cell carcinoma, it is remarkably radiosensitive. And there have been a lot of nice studies, many of which have been led by the leads on the Samurai study, including Chad Tang from MD Anderson, who's done some really nice work looking at oligometastatic renal cell carcinoma and how excellent the responses are to high dose focused radiation. So it takes a long time to overcome these sort of historical perspectives and narratives, but that's really what we're striving to do in this trial. So it definitely took time to work this through. It took a lot of discussions and presentations on the available data. But ultimately, like I think many things in the cooperative groups, I was really happy to see that the NCI was ultimately supportive of this trial.
It's funny you say that renal cell carcinoma or kidney cancer is radiosensitive. I actually really couldn't agree more. I think it's a big misnomer. Historically in radiation biology, we we look at radio responsiveness, how much does a tumor shrink or respond to radiation? And and that was a surrogate for, and probably an inappropriate surrogate for radiosensitivity. But when you look at renal cell carcinoma, when using large fraction sizes, even to fairly modest doses, they are indeed remarkably radiosensitive. And my kind of joke is that, renal cell carcinomas are radiosensitive, and actually a tumor that has always been called radiosensitive, neuroendocrine small cell carcinoma, I actually think that's pretty radio resistant when you look at local control rates. So, I think this is a really important concept you're touching on, that radio sensitivity is actually much different from radio response in a petri dish. So, um, in any case, I wanted to move on to a slightly different topic pertaining to GU012. As you probably know, there's been a slew of trials, both by NRG Oncology and by other investigators, combining radiation with PD-L1 immunotherapy for things like lung cancer, head and neck cancer, brain cancer, to name a few. We've even talked about some of those trials on this podcast. A number of those clinical trials have not been successful. What is different this time? What is different about renal cell carcinoma that makes you think combining radiation and immunotherapy is going to have a benefit when this approach hasn't worked all that well for a number of other cancers recently?
Yeah, I think that's a great point, and we were talking a little bit about this before we started recording the podcast. I think we have to frame the narrative slightly differently, and I feel pretty passionately about this because there have been unsuccessful trials. I hesitate to use the word failure because I don't think they're failures, but because there have been trials that have not met their primary endpoints, I think we have a lot to focus on and learn about the way that we introduce radiotherapy with immunotherapy. So we were mentioning a little bit different disease site in the setting of lung cancer. There have been two landmark studies, Pacific 1 and Pacific 2. And if you look at the results of these trials, both involved radiation therapy in different sorts of combination with immunotherapy, in this case, durvalumab. Pacific 1 was a wildly positive trial. Okay, the overall survival difference was truly incredible. So I would call that trial a winning trial, massively winning trial, with a combination of radiation therapy and immunotherapy. Now, it wasn't radiation therapy concurrently with immunotherapy, but the patients were treated with radiation therapy and then they received immunotherapy after that. Now, when you look at the Pacific 2 trial, another phase 3 trial looking at the combination of radiation therapy and immunotherapy, it was a negative trial. Now, there was a relatively modest difference between them, and it was largely just the timing of immunotherapy being given with radiation therapy. Now, I look at that as a huge opportunity. Something very, very significant is going on here when you look at a very small difference of sequencing. So there is a huge discovery that is pending in the arena of combining radiation therapy with immunotherapy. And so I think there's a lot of people that are focused on discovering this. But there are a lot of other studies that are available that are out there that really don't get a lot of attention for a number of reasons. Either they did not accrue well, or their endpoint did not hit a pre-specified value that was described as significant. Nevertheless, when you dive into the results, they really are quite compelling. I mean, one example is a small study that was published in JAMA Oncology in 2019 called the Pembro RT study, that in a similar sort of design to what we're doing for Samurai, looked at combining high-dose radiation therapy with immunotherapy. Now, the overall results of the trial were negative, but I think when you dive into the outcome curves and you look at the differences in the patient population, in the outcomes that were reported, I certainly think there's some hypothesis generating findings that might be worthwhile investigating further. So I feel that the only way that we as oncologists can really address this going forward is to design new and different studies that are testing the combination of radiation therapy with immunotherapy in new and different ways. And that should be very different sorts of approaches. So what we're trying to do in this study is an approach that has not been tried before. And that's the approach of just treating the primary tumor. And I shouldn't say it hasn't been tried before. It hasn't been robustly tried before in a randomized phase 2 setting. And there are other trials that are looking at similar questions to this, so I don't want to discount those. But we really wanted to look at how can we do something slightly differently that we know is probably safe, but do it in a prospective randomized trial, collect really granular data, as well as bank different sorts of biological specimens so that we can try to study this more comprehensively going forward.
I think that that is not only a really reasonable approach and logic, but incredibly important. As you've pointed out, we have this tendency to frame these narratives as trials being unsuccessful or failures. I'll go ahead and use the failure word because I think our field uses it frequently, when really what we need to be thinking about is strategy and how there is timing differences and ways that we can harness that underlying biology to the advantage of our patients. So one thing that we ask all our guests who are principal investigators of ongoing trials is, what is a strategy in terms of increasing trial accrual? And do you have any personal strategies with Samurai that you're leveraging to improve accrual to this trial? And also, how can we as an NRG oncology community help?
Great question. So I'm really trying to get the word out about the study. One of the biggest jumps we had in accrual was after it was featured in one of the main presidential sessions at Astro. We saw just a huge surge in accrual in the 2 months after Astro. We accrued an incredibly high number of patients. So I feel that once people know about this study, they really like it. And I always try to get colleagues and peers, particularly medical oncologists, to hear about the study. It's an easy randomization. It's an appealing question. It's something that many patients can enroll in. And so I think a lot of it is just getting the word out. So that's part of the reason why I'm happy you all are doing this. I appreciate being a guest on the podcast, because the more we can get the word out, the more I think accrual will improve. The other thing I want to highlight is that we recently updated and slightly changed the study so that patients can come in on immunotherapy already. So many patients come in and they've already started immunotherapy in the community, or they've started at another hospital. And those patients are often ineligible for many systemic drug-related clinical trials that are testing a new systemic agent because they've already started a standard of care immunotherapy. So this is an option for those patients that the team may want to put them on a clinical trial, but doesn't have a trial that they're eligible for. That's a wonderful patient population that could be enrolled in this trial. And the other thing I want to highlight is there are many centers that have not done renal SBRT before. They just don't have any experience with it. They look at it as intimidating and a little bit uncertain. That is a huge benefit of NRG oncology, and it's a huge benefit of enrolling your patients in a trial like NRG-GU012, because I insisted when we designed this trial that all patients underwent prospective peer review before they were treated. Now, that means that myself, Shankar Siva, Chad Tang, or Himanshu Naga are all experienced radiation oncologists that have done a lot of abdominal or renal SBRT, review those plans before the patients are treated. We can call centers, we can provide feedback, we can answer questions. We actually go through them in a lot of detail. So that's very reassuring to centers that maybe haven't done this before. So my hope is by getting this word out that we'll really be able to increase accrual and really address this patient population in a robust way.
So I've got one last question from one of my mentors, Dr. Samantha Powell. He's my mentor in the American Society of Clinical Oncology Leadership Development Program, and I suspect you probably know him. He's a medical oncologist specializing in kidney cancers at the City of Hope Cancer Center in California. And so he would like to ask if you could elaborate just a little in layman's terms on the exploratory biomarker objectives of GU012. And can you explain in a simple way what exactly are these biomarkers that you're looking at and what are you hoping to learn here?
Yeah, I mean, great question. I would say on this, it's really TBD. We have a lot of grants that are pending right now. We have a lot of ambitious and exciting initiatives that are in the works. I don't want to get too much in the detail of those. They're being led by lots of different members. My co-principal investigator, Raina McKay, who's just a super gifted and talented medical oncologist. I should have started out by thanking her in the beginning. She's been a phenomenal partner to work with on this trial and is doing a lot of just incredible work in this space. We are banking whole blood in both EDTA and cell-safe tubes. That's pre-treatment, post-treatment, and at progression. All of that is going centrally to a lab at the University of Wisconsin, not the Medical College of Wisconsin, where I am, two different places. But nevertheless, we do have a lot of things planned. I probably will table that discussion for now because we're not sure what's going to get funded and when, but stay tuned on that one. It's going to be exciting.
Well, Dr. Hall, it's been a pleasure having you, and both Lauren and I want to wish you success, not just with GU012, but also as chair of the Medical College of Wisconsin Department of Radiation Oncology. Again, whenever an NRG investigator gets a leadership role like this, it's a win for the home team.
Well, thank you both so much. Thank you for doing this. This is really, really exciting, and I really appreciate you having me on.
So, in closing, I just want to say that when I started medical school 20 years ago, this was 2005, I'm dating myself, stage 4 metastatic renal cell carcinoma was almost uniformly a death sentence, and not just a death sentence. It was maybe a couple years at best, as Dr. Hall alluded to in this podcast. And it's hard to believe that today, almost half of patients are alive at 5 years, perhaps more in certain centers. With all of the advances we're making in the understanding of the wiring of kidney cancer. But this is only possible through clinical research and clinical trials. And so, with that in mind, for Kidney Cancer Awareness Month 2025, I'd like to leave all of you who are listening with the message of just what is possible and how many lives we can save by supporting and participating in clinical research and clinical trials. The NRG Oncology Group is supported by grant funding from the National Cancer Institute, and content of this podcast does not necessarily reflect that of the National Institutes of Health. Thanks, everyone, for tuning in, and happy clinical trials.